morning. We'll just start. Today I'm covering several topics for the pancreas. We'll start with the cystic neoplasms of the pancreas. That's also a pretty extensive topic. We'll try and sort of condense them as much as we can within the time. So within the cystic lesions of the pancreas, there are three main ones that you need to know, starting out with IPMN. As you all know, there are three different types. There's a main duct IPMN, there's a branch duct IPMN, and the mixed type. Second cystic lesion of the pancreas is the mucinous cystic neoplasm. And the third one, which is less common, is the serous cystic neoplasm. So usually, as most of these cystic neoplasms will be found as an incidental finding on imaging done based for any other reason, be it trauma, be it anything else. And so what is the workup for these lesions before we even make the diagnosis? So any cystic lesion found incidentally on imaging, which is less than 1 centimeter in size, you can follow up with a CAT scan in 3 to 6 months to see if it grows in size. Because the cutoff size is 1 centimeter or greater for further workup to evaluate for two things: high risk stigmata or other worrisome features. So if you have a cystic lesion that's less than 1 centimeter, you probably need to get a CAT scan, say 6 months or 3 months, based on your liking. And then if it does grow, if it grows in size to greater than 1 centimeter, then you got to do further workup at that point to evaluate for high risk stigmata or worrisome features. And what do you do for that? So again, the workup would include either a CAT scan with the pancreas protocol. Now you guys know what a pancreas protocol is? Francesca, what's a pancreas protocol?
There's like thinner slices, and then they look at the venous phases and arterial phases.
So there's an arterial phase, a late arterial phase, and a venous phase. And so the late arterial phase is actually the important one because it distinguishes the pancreatic lesions. Because for, say, adenocarcinoma would actually be hypodense or hyperattenuated. It won't light up as much as the normal pancreas would. But say an endocrine tumor of the pancreas would actually be more prominent or more or hyperdense or hyperattenuated on the CAT scan. So the three phases of the pancreas protocol. So CT scan is one option. The other option is MRI, gadolinium enhanced MRI with MRCP, and that actually is the recommended imaging to evaluate for cystic lesions, because that also shows you the ducts better. And then the third modality is EUS with an FNA, which allows you to get a sample for cytology, and also allows for cystic fluid analysis, which also helps in distinguishing these cystic lesions. So just an image of, so which one do you think is A? Is it the three different types of the IPMN? So A would be what kind? I'm sorry? Rachel? Yeah. B would be what? So that would be branch duct IPMN, and C is actually a combination, the mixed type. So you have the main duct dilated as well as the side ducts. So what are the typical features for MCN versus branch duct IPMN versus serous cystic neoplasms? So basically, it's sometimes hard to distinguish MCN from IPMN, especially branch duct. And there are certain things that you got to look for. One of them is the age. So MCN will usually present in the, first of all, it will predominantly be in women, MCN would be, and it will present in the 4th to 5th decade of life. Branch duct IPMN usually is about 50-50 males versus females, and presents late in life, usually the 6th and 7th decade of life. MCN may have some calcifications. IPMN is multifocal. because there's a concept called field defect that's associated with IPMN which actually is the reason why you may have more than one IPMN sites on the pancreas simultaneously. Important thing here is the MCN would only infrequently have communication with the pancreatic duct, while branch duct IPMN usually will have it in most cases. Not always, but in majority of the cases will have communication with the main pancreatic duct. The pancreatic duct for MCN would be normal in size, maybe slightly deviate or push to the side from the cystic lesion, but in branch duct IPMN, it will be dilated in most cases, at least greater than 5 millimeters. So after you're done with the imaging and stuff, we talked about the EUS-FNA being important to distinguish one lesion from the other. And what's important to look at here is, first thing to look would be, so you've had your CT or MRI done and you have a lesion that looks cystic. How do you know distinguish one from the other? So you'll do a EUS-FNA. Some of the things you look for is you'll have to get a sample of the cystic fluid, and then you send that for a CEA level and also an amylase level. So for IPMN and both MCN, the CEA level is usually high, and that just, if the CEA high is, it indicates that this is a mucinous fluid versus a serous fluid. Because for serous cystic tumors, the CEA, as you can see, is low. So that's the first thing you gotta look for. The second important thing to distinguish, so as CEA is elevated for both IPMN and MCN, the next thing to look for is the amylase level. As we talked about on the previous slide, for MCN, there is usually no communication with the pancreatic duct. So what would you expect the amylase level to be for MCN if there's no pancreatic duct communication? Low, because there's no communication. So that's the next important thing to look for in the assessment of the cystic fluid. So if CEA is high and amylase is high, usually you would suspect most likely probably IPMN. If CEA is high and amylase is low, you expect MCN. Also the type of fluid, the viscosity for mucinous lesion, of course, as you know, because it's mucin, it'll be thick, clear liquid, versus for serous cystic tumors, fluid will be thin, maybe bloody. What's also important to remember is when you take a little sample for the MCN, as we talked about previously, there's usually present in females in 95% of the cases. One of the things that they may give you on the question is a sample was taken of the cystic fluid and it shows ovarian stroma on the path. What would that be consistent with? Anyone? Yeah, mucinous cystic neoplasm. So that's classic for MCN again. If on path or a sample of the fluid then comes back for ovarian stroma, classic for mucinous cystic neoplasm. So that also distinguishes MCN from IPMN. For serous cystics, similarly, sometimes they can give you this. The cystic fluid comes back with glycogen-rich cuboidal cells, and that's consistent with serous cystic tumors. So this is kind of a good slide that covers quite a bit, and you could get one of these on either your in-service or your actual boards. So treatment for IPMN main duct, there are certain principles. So mean frequency of malignancy in main duct IPMN is over 60%. So current recommendation actually is to resect main duct IPMN regardless of size. Some papers you look at may say, oh, resect only for greater than 1 centimeter and follow for anything less. I think that the safest option to know is if the patient is surgically fit and there is main duct IPMN regardless of the size of the duct, go for resection based on high probability of malignancy associated with it. And so, as I mentioned previously, there's something called a field defect that's associated with IPMN. So, have you guys scrubbed with Dr. Chu or Dr. Zabari for an IPMN resection? So, do they do anything after the specimen is resected? No, like sending the specimen to the path lab. Do they do a frozen? Yeah, so that's important for IPMN, is because of field defect, you wanna, where your resection margin is, you need to know if there is any associated high-grade dysplasia or malignancy. Because if there is, then you gotta go further down the pancreas and take another margin. And that's one of the reasons why sometimes you will actually end up doing a total pancreatectomy for IPMNs, because if your resection margin still comes back as high-grade dysplasia or malignancy, then you gotta keep going further down. And there comes a point where only if the little tail of the pancreas is left, the duct isn't big enough for your anastomosis. So what do? You just have to do a total pancreatectomy. So that's just the main duct IPMN. They talked about the fish mouth appearance, petulous, duodenal, papilla dilated by the mucin. So this is a classic ERCP finding. For branch duct IPMN, as we talked about, the two things you got to look for is either if they have associated high-risk stigmata or they have worrisome features. Those are two things you got to look for. So when you have somebody with branch duct IPMN on imaging, what you look for, if the patient has obstructive jaundice with a lesion in the head of the pancreas, or there is an enhancing solid component within the cyst, or if the main pancreatic duct is greater than 1 centimeter in size, these are what they call high-risk stigmata. So if any one of these features are present, the next step is resection. Okay. So if none of these features are present, then what you look for are the worrisome features, which could be patient may have pancreatitis, or cyst is greater than 3 centimeters, there is thickened cyst walls, main duct size is between 5 to 9 millimeters, mural nodularity, abrupt change in the pancreatic duct with distal pancreatic atrophy or lymphadenopathy. So if any of these features are present, now, again, a little crossover sometimes based on surgeon liking. I mean, in some papers, if you read, if the cyst is greater than 3 centimeters, they put that down as a high-risk stigmata too. But this is I got this algorithm from a landmark paper by Tanaka, Tanaka. He's a Japanese surgeon who's done a lot of work on pancreas, and these were the guidelines that came out in 2012. So if there are any of these worrisome features, then what do you do next? You'll do an endoscopic ultrasound. Are any of these features present? Mural nodularity, main duct features suspicious for involvement, and cytology suspicious or positive for malignancy. Then any of these features are present, then you'll also proceed with surgical resection. The others, for the most part, if they don't have any of this, don't worry about the size here. This is just, you don't need resection. It's just a question of following these patients. Now, based on the size, there are different recommendations, but I don't think you need to know. I think the important thing is, with high-risk stigmata, you got to proceed with resection. And if any of these worrisome features are present, then you proceed with the endoscopic ultrasound. And if any of these features are present, then you proceed with resection. So that's what you need to know for the branch duct IPMN. Any questions so far? With MCN, again, just like main duct IPMN, the recommendation is for resection regardless of duct size. With MCN, it's the same thing. Resection is indicated regardless of size or mural nodularity. Now, we talked about MCN could have how to distinguish. We talked about, so what would be the cystic fluid analysis? The CA be high on MCN or low? High amylase level. And then the ovarian stroma. And so inherently, the malignancy rate of malignancy associated with MCN is about 15%, but resection is still indicated because, as we talked about, these present 95% or greater in females and at a younger age, between 4th and 5th decade of life. So you got to follow them for a long time. So based on that there's still, these people, say somebody's diagnosed at age 40, they may still have another 35 to 40 years to live. And so following them for 40 years is a problem. And so even though the overall malignancy rate is low, the recommendation is to just proceed with resection of the MCN, regardless of the size or mural nodularity. So that's in regards to the cystic neoplasms. Next thing we'll cover are the ampullary cancers, not the periampullary, the ampullary, the difference between the two. So what's an ampullary cancer? It's a cancer arising from or within 1 centimeter of the ampulla of water. Important thing to know is that they do carry a better prognosis than adenocarcinoma of the pancreas or the bile duct. So they have about even up to 50% 5-year survival. Most of the periampullary cancers at best will have probably about a 20% 2-year survival. These cancers have up to 50% 5-year survival. So important thing to know is just like for your colonic adenocarcinomas, these adenocarcinomas, ampullary adenocarcinomas also arise from adenomas. Up to 90% will derive from adenomas. Risk of lymph node disease correlates with size. So the bigger the size of the cancer, the more chance that there is lymph node involvement. And if there is lymph node involvement, this translates into high probability of distant recurrence. So based on what score tells you is that you could undertake local resection for either in situ disease or high-grade dysplasia. I looked up papers, most of them suggest as long as patient is a good surgical candidate, even for in situ or high-grade dysplasia, they've recommended a pancreatic or a Whipple. But based on the score, your score curriculum, they said you could undertake just local resection for in situ disease or high-grade dysplasia. For any invasive disease, T1 lesion, you got to do a formal resection because of associated lymph node involvement. You need to clear the lymph nodes, as we talked about, that the bigger the size of the tumor, the more likely there is lymph node metastases, and you got to take those out. Otherwise, you leave them behind, there's a high chance of metastases further down the line. So pancreatic duodenectomy for invasive disease or lymph node involvement. Now, let's say on imaging, you see enlarged lymph nodes around where the lesion is. So even if the lesion looks, on biopsy, let's say it showed in situ disease, but there is enlarged lymph nodes around the area, then at that point you gotta just proceed with formal resection because of the possibility of lymph node involvement. Neuroendocrine tumors, as you know, the two different types, the functional and non-functional. We'll talk about the functional first. So 5 main types. You have the insulinoma, symptoms, hypoglycemia, gastrinomas, biapomas, the WDHA syndrome, or watery diarrhea, hypokalemia, achlorhydria, glucagonoma, glucose intolerance, necrolytic migratory erythema, hypoaminoacidemia, somatostatinoma, steatoria, achlorhydria. So I remember getting a question when I was a resident on the in-service exam about a patient having necrolytic migratory erythema. And the question was, how do you treat it? before resection of the lesion. I mean, usually once you have the glucognoma resected, it should get better. But while, you're managing the patient prior to surgery, how do you treat this? No, not retreatment. I mean, because they'll be all over. It's not going to be one area. So you can't be, and pretty much patient may present extensively. Huh? I'm sorry? Yeah. Yeah, exactly. So treatment is, because these lesions present because there is, as we said, hypoaminoacidemia. There might be also deficiency of fatty acids as well as zinc. So those are supplements that you gotta give the patient to treat this erythema or lesions. So we'll talk about some of these in a little detail. So insulinoma, most common functional endocrine tumor of the pancreas. Usually they're solitary. Most times they're benign. Sometimes, very rarely, could they be malignant. Importantly, occur uniformly throughout the pancreas. Present with the Whipple's triad. What's the Whipple's triad? Anyone? Improve the symptoms. Yeah. So diagnosis, of course, you'll check for insulin levels as well, but the classic test to diagnose insulinoma is a 72-hour fast, and you got to check the sugar levels. Most of these patients will actually, the sugars will drop to below 50 within 24 hours. But if they don't, then you can actually continue the fast test for up to 72 hours. Once you have a diagnosis made based on the biochemical testing, next thing would be to localize it, and the way to do it would be to get a CT scan or an MRI. Important thing to remember with insulinomas is 50% are too small to be detected by non-invasive imaging. And so what do you do for that? Then you'll have to undertake an endoscopic ultrasound to see if you can better visualize them. Even if you can't do that, they talk about calcium arteriography, which I haven't really seen that in any institution. The next best thing would be to take the patient to the OR and then do an intraoperative ultrasound to better localize. In fact, it's recommended to do it for every patient that you take for resection for insulinoma, because you want to make sure, let's say on CAT scan you just see one. With intraoperative ultrasound you might see another lesion. And so it's always important to do that intraoperatively. Management, the two parts to it. One would be to control the symptoms, and that the treatment is with diazoxide, and that inhibits the insulin release. So that is just for temporary control of the symptoms. But of course, the definitive treatment would be surgery. As we talked about, you got to do an intraoperative ultrasound. With insulinomas, because most of them are benign, you can get away with enucleation. Based on one of the questions on the score, when I looked it up, I didn't find it, but based on the question, one of the answers, you can only enucleate if the tumor is greater than 2, this is actually millimeters, not centimeters, from the pancreatic duct. Again, I didn't find it anywhere else. This is just based on one of the answers, so probably good to know for you guys. So if the tumor is greater than 2 millimeters away from the pancreatic duct, you can enucleate. If it's closer than that, you can't, because then you worry about if you take part of the pancreatic duct as part of the specimen, then there is a high concern for pancreatic leak. So that's why you gotta make sure that there is some margin of normal tissue away from the pancreatic duct. And if it's too close, then the next step is to do a pancreatectomy. Now, based on where it is on the pancreas, it could be a distal pancreatectomy, but if it's in the head of the pancreas, then you have to do a Whipple. Next is the gastrinoma. There's Olin-Jellison syndrome. Important thing in contradistinction to insulinomas, these are malignant for the most part. 20% are associated with MEN. And if there is MEN, then usually you'll find multiple lesions, but majority are still sporadic. And if they're sporadic, then usually they'll be solitary. But they'll still be, majority of them will be malignant. And that's distinct to the insulinomas, which are benign for the most part. Symptoms, you'll have peptic ulcer disease, and you'll find ulcers in unusual places such as the jejunum instead of the regular, either gastric or the duodenum. And also these patients will have diarrhea because of the high acid output in the stomach. That just causes diarrhea. Diagnosis, if somebody, you suspect gastrinoma, first thing to do is send a serum gastrin level. If it comes back as greater than 1,000 picograms per ml, that's your diagnosis of gastrinoma right away. If, however, the gastrin level is between 100 to 1,000, then the next step would be to do a secretin stimulation test. And if the gastrin level increases by more than 200 pgs per ml from the baseline, then that confirms diagnosis of gastrinomas. Once you have your biochemical confirmation, then the next step, of course, would be localization. So you can do a CT scan, which is the preferred modality. You could do an MRI if there is suspicious lesion that show up on the CAT scan, which you can't say for sure if it's metastatic lesion or not. Octreotide scan is one also that can localize the gastrinomas for you, both the primary lesion and metastatic lesions. EUS, just like insulinoma we talked about, and of course the intraoperative ultrasound. For management, again, just like insulinoma, first step is to actually control the symptoms, which in this case would be give omeprazole 4D BID, which will control the symptoms of peptic ulcer and hopefully also improve the diarrhea. Definitive treatment is, again, surgical excision. Always do, again, intraoperative ultrasound to make sure there are no other lesions that you're missing. And a duodenotomy is always recommended because intraoperative ultrasound is not good for lesions present in the duodenum. Now, do you guys remember the gastrinoma triangle? Can one of you guys describe it for me? How about you? John? The gastrinoma triangle, do you know the boundaries? The duodenum is one end of the triangle, the cystic duct with the common bile duct junction, that's the other end of the triangle, and goes through the neck of the pancreas. So those are the three corners of the triangle. And that's where you'll find majority of the gastrinomas. So for non-functional neuroendocrine tumors, again, when you have a mass that shows up incidentally on a CAT scan and it's not cystic, we've talked about cystic, this will not be cystic. So some of the things you got to do is start with biochemical studies. You'll send a chromogranin A, that's pretty sensitive for neuroendocrine tumors which are non-functional. Pancreatic polypeptide, they talk about sending the gastrin glucagon level as well to make sure it's not a functional lesion. Ask patient about their past history. And then for imaging, again, same thing, CT, MRI, octreotide scan, intraoperative ultrasound. So this is kind of controversial in terms of which lesions do you resect versus which you can watch. And so for the exam purposes, I think all you need to know is 2 centimeters is usually the cutoff size. If the lesion is non-functional and it's greater than 2 centimeters in size, you need to proceed with resection. If it's less than 2 centimeters in size, the grades that based on the WHO recommendation, the grade is based on mitosis per high power field as well as the Ki-67. And so for grade 1 disease, you can observe versus grade 2 and 3. you have to proceed with resection. I think for your level, I think it's the size that probably is most important. Anything over 2 centimeters, need to resect. If it's less than 2, usually you can observe with CT scans every 6 months or so. Last thing, the pancreatic adenocarcinoma, as we talked about previously, what's important to know is that these lesions will show up as hypodense on the CAT scan, which means they will be not as prominent or will be darker than the normal pancreatic tissue on the CAT scan, while the endocrine tumors normally would be more bright or brighter than the normal pancreatic tissue. What's important to know is if patient presents with jaundice, obstructive jaundice, and there is a lesion noted on CAT scan, you can proceed with surgical resection. You can proceed with Whipple. You don't always have to have a biopsy, as long as it doesn't have the locally advanced features, which we'll talk about. If there is, however, any doubt of what it is, you can proceed with endoscopic ultrasound, which allows for biopsy and allows for visualization of the lesion, whether there is abutment of the vessels or not. So that's the advantage of the endoscopic ultrasound. But you don't always have to do it. If you're confident that this is it based on patient symptoms, based on CAT scan findings, you can just proceed with surgery also. So what they what they want you to know is, there is basically the concept of borderline resectable. So there are 4 terminologies they mention for is locally resectable, which is, means that you can go ahead and resect the specimen. There is a concept borderline resectable. Then there is the next thing is locally advanced. And then the 4th thing is metastatic disease. So the important concept is for the borderline resectable. There's several different facets to it. So what you need to look for is association or abutment of the tumor with the SMV, portal vein, the SMA, hepatic artery, and also celiac axis. Usually, though, most questions I think focus on the SMA and the SMV. So there were several different guidelines, but this is, the alliance. They've sort of come up with a one formal recommendation. If there is greater than 180-degree interface of the vessel wall circumference with the tumor, with the SMV. So if there is greater than 180-degree abutment or even occlusion, short segment occlusion, which can be reconstructible. So you can resect that short segment which is occluded and then do a formal resection. That counts as borderline resectable. With regards to SMA, again, if there is tumor vessel interface of less than 180 degree, that's the other criteria that this will count as borderline resectable. For hepatic artery, reconstructible short segment interface of any degree between tumor and vessel wall. So again, if there is short segment which could be resected and then reconstruction done of the hepatic artery, that also counts as borderline resectable. And for celiac axis, less than 180 degree of vessel wall circumference again. Again, most of the questions usually that I've come across focus on the SMV and the SMA, so that pretty much is what you need to focus on. So if there is if it's borderline resectable, what's the next step? Pardon? So what would you give? Radiation or chemo? So it's actually chemo radiation, both. That's what you would do. And so let's say you do that, then you have to, if you have to restage, what are you looking for?
You're looking for regression of the tumor.
Okay.
See if it got away from the vessel. Lymph response.
So let's say that tumor size is about the same as it was pre-operative or pre-neoadjuvant chemotherapy.
That's a surgeon's preference thing, because you might have stopped, but if you were progressing or might have had no response at all.
So what would you do then? What would you do? Would you want to?
You could offer the patient surgery. That would be an option, but tell them, it might be cancer that responds with adjuvant after, they might not have any better prognosis.
So current recommendation, yes, is as long as the tumor hasn't progressed, which could mean hasn't metastasized or hasn't grown bigger on neoadjuvant chemotherapy, even if it looks the same as it did before you did the neoadjuvant, current recommendation is to offer surgery. Go and take a look. Most times they've looked at series from MD Anderson, they've said most of these would be resectable. So that would be the recommendation. Okay. And that's it. Do you guys have any questions? So one last question will end. So we have a cystic lesion noted on imaging. You end up doing an endoscopic ultrasound, take a little sample of the fluid, the CEA level and the amylase level is low. What do you think that could be? MCN, IPMN, serous cystic neoplasm? So serous cystic neoplasm. All right. Any questions?